Hello friends, my name is Managemnt Xavier. I'm your health medical service provider, and always in my tutorial, if you're new, we majorly talked about health, we talked about employment, jobs, and also we talked about career growth and development, evangelisms, and entrepreneurship. So friends, if it is your first time, you are more than welcome, and I would want you really to do simple tasks. I don't want to assign you to do simple tasks. You and me, just go below the video channel, just find where it is written subscribe, just click subscriptions if you think this is really of help to you and the society. But also for our homeboys and homegirls, as our culture has always been, just go below the video, press subscribe if you've not yet done it. By doing that, meaning you are really doing service to the society and community, but also you're giving me a motivation that I should bring you guys more of healthy tips and other essential subject matter that has to be really discussed. So for today, we are going to look at very essential subject matter, which is majorly practiced in medical healthcare, and this one I really highly recommend it to the first headers and medical practitioners to be very attentive on this subject matter. Today I want you and I to really have a look, a deeper insight of understanding this subject matter, which is airway breathing and oxygen therapy. Airway breathing and oxygen therapy, majorly that means we are going to be so much concentrated and focused in our upper respiratory system. In our respiratory system, we shall basically get to know some of the organs that are likely be affected by airway breathing and oxygen therapy, and these are the essentials organ I would want you as a first header, but also as a doctor or a nurse or therapist, any medical practitioners who are in the field, who is licensed to get this right from the beginning. So as I told you, my name is Managemnt Xavier. You can drop your likes and also can write a comment down the comment sections, but also you can subscribe, meaning that we are communicating. By doing that, my friends, it means you have really given an impact to the community, but also society. So let's go straight away. So before we could go a little longer, I want you to really get this. Let's get to know the outline or objectives of this. I would want us to really approach these three basic objectives. By the end of it, you should be able to know how to do airway assessment, but also management by the end of this tutorial. Yeah, don't you think that's going to really contribute a lot, and you really save lives in your community, society, but also wherever you'd really be, duty would call you from to wherever duty would call you to, you'd be able to really demonstrate and exhibit some skills and knowledge prior to this. Plus, by the end of this, I would also be expectant that you'd be able to really do breathing assessment and also do management of it. Yes, so those are the things, and later after about this, we shall be able to really know how to really know oxygen therapy as an entire set. So friends, this is what I would want you to know in a very brief introductory part of this, friends. Airway breathing and oxygen therapy, it has a framework which has been really developed by the World Health Organizations. That is the ABCDE approach. That is the approach that provides a framework for the systematics. It provides a framework for the systematic and organized evaluation of actually heal patients in order to rapidly identify and intervene for life-threatening condition at all, if there is a life-threatening condition. So the following, we shall be focusing on the following airway breathing component of ABCDE. So let's dive in together. So before we could dive in, I would want you and I also to get to know that when it comes to airway breathing and oxygen therapy, there's one thing that we should put in mind, that is you must you will never walk away from this. You have first to know the airway anatomy. In airway anatomy, friends, I would just want you to know that I wish I have a model, but I don't have a model. But I just ask for your patience. Let's try to use what we have. I'm going to use my anatomy as a whole for you to get it well. So, as I'm going to use my airway anatomy, I want you to know their basics organs that you should get it well from the beginning. That is, let's start with the cavities. In our airway anatomy, we have major two cavities which is within our airway anatomy. We have the nasal cavities. Yeah, this is the nasal cavities. The nasal cavity simply helps keeping the internal organs, that really helps in trapping dust and also humidifying the air, all the oxygens that we really take in. We have also some other organs like hair inside that help trapping the dust, but also the organisms that are really not supposed to enter, plus some other foreign body. For instance, whenever you hear there's something which is unfamiliar has gone through your hair nostrils, there's a way you sneeze. Yeah, that is a response. It's a reaction that your body is trying to respond that this is not what we are used to. So it will try so much to really expel them out. So that is what is covered by nasal cavity. Don't you think that is really giving you a more additional knowledge? Yeah, let's go. Also, then another cavity that I want you to know, it is the oral cavities. The oral cavities are the inner side of the mouth. Oh yeah, if you can really get that one well. The mouth has some other organs like the tongue, which is really there to really help you know the taste. It also has salivary glands. It also have teeth. It also have some other tissues that are really helpful for you to really grab some things inside. But now, at times we also breathe using our mouth, but that is not so much it's not very well recommendable for us to be practicing, because we cannot easily filter the air which we really breathe through the mouth like the one which goes through the nose. However, these are all our airway anatomy. And then after having known about these two cavities, I want you to know that we also have what we call throats, or other people call it larynges, other people call it opharynges. Yes, this is what is just immediately after the mouth. We have opharynges, which is it is the area behind the tongue. After the tongue, that's where now you have your larynges or pharynges or throats. Other people call it that way. So I want you to know those are the airways channel that really help us get this well. So majorly those are the few things. However, you may have time and also get to know more about epiglottis. You also have time and get to know about nasopharynx. Epiglottis, let me just let you know a simple term of it. When someone talks about epiglottis, is just a mechanism that covers the opening of the trachea. It is just a mechanism just cover the opening of the trachea. That's when it's, for instance, it acts when food or swallowed in or something, it traps certain things which enters in. So that is simply about epiglottis. So now, after knowing the basics of this anatomy, I know by virtue of this you'd have known some basics that are really there in airway anatomy. I just want you to be brief, but for more understanding, you can go to anatomy book or any source, and you really understand more of this detail of anatomy. So let's now go to our objectives. That is number one. Our number one objectives is airway assessment. Yes, at the end of it, I want you to be really able to really do assessment. Now, how do I assess for airway breathing and oxygens? Here it is. If you want to do your assessment on airway breathing, you do the following. Number one, you need to really get to know that can the patient talk normally? If you want to know if there's something wrong with the patient or not, can the patient talk normally? If yes, then the airways is open. But also, if the patient cannot talk normally, you can easily be able to tell that there's a problem with airway pattern. So by that you can really see what way to do an intervention that really you have to put in place. Yes, then the next thing is that you'd have to look for a chest wall moving, and you also listen to see if there is a airway movement from mouth or nose. Yeah, you in actual sense there's another term they call it flaring. You'd be able to see, is there such a movement within the nose or chest? Not chest wall, is chest wall really moving or something like that? If you can really hear that or see that, then meaning the airway pattern, it's okay. But also you should be able to listen for abnormal sounds. If the airway pattern is not okay, you'd be able to hear for some abnormal sounds such as stridor, you'd be hearing grunting, you also be hearing snoring. Or else, if not that, at times we often hear hoarse or raspy voice that indicate there's partial obstructed airway rather. Whenever you hear hoarse or raspy voice, that means there is a partial obstructed airway. Doesn't mean it is fully obstructed. It means partially has been obstructed. So that is what you should be able to tell. And then also you'd be really hearing stridor plus swelling or hives. That will suggest severe allergic reactions. That is, in medical term, we call it anaphylaxia or anaphylaxis. When you hear stridor plus, when you see the stridor plus swelling or hive suggests severe allergic reaction, which is called anaphylaxis. Yes. Also, let's look. By the end of it, you should look and listen to fluids as blood. You should look and listen to the fluids such as blood, vomit. If it is in the airway, if it is in the airway, meaning there's something wrong, you have to really figure out what is that. Then, also another thing you have to do as you're doing your assessment on airway pattern, you should also look for foreign body or something which is really blocking the airway. But also, upon that, you can as well as go ahead and also do abnormal swelling around. You see if there's abnormal swelling around the airway and altered mental status. So, you know, when there is when the airway pattern is being compromised, patients or casualties tend to really develop altered mental status. By that, when you do your assessment, you'll be able in position of really identifying this patient has developed mental disorder or some uncertainty. By that, you'd be able to tell. But also, on that, you can also go and check if the patient is able to swallow saliva. Yeah, you ask the patient if he can swallow saliva, let him swallow, or drooling, or something. So these are the primary how you can do the airway assessment. I hope by that you've gotten something. Now let's go straight away to the management, having done assessment. But now, before you do your management, you know, in every approach we do as a health medical practitioner, we have aims, we have objectives. What is the aim of the management here? Right, friends? I love this because it's a life-changing and it's a life-saving subject matter. For a first aiders, you are just moving a step away from here. So what would be the aim of our management? Number one aim is that to find if the patient is unconscious and not breathing normally. And after finding that, we have to really, that is the objectives. We have to do intervention as soon as possible. But also to figure out if there's no trauma in our open airway using the head tilt and chain lift maneuver. But also the next objectives here should be concerned for trauma. It is to maintain cervical spine immobilization and open the airway using the jaw thrust maneuver. So for our first aiders, this is how we are going to do it. After now, do you know our objectives or aim of management? Let's now go to the management. Number one, what you're going to do in our management if you're managing airway incompatibility. Number one, airway management. Number one, you have to position yourself at the head of the patient. You as a first aider, or a nurse, or a doctor, or a midwife, or wherever discipline you're in, you have to position yourself at the head of the patient. The patient lies on the couch, and you have to just be right over here at the head. In such a way, you'll be able to position yourself and monitor and observe what is right and what is not right. Then the next thing here is what you have to do is you have to place the hand at the side of the patient face. You place your hand at the side of the patient face. That will really help to really, of course, maneuver and see what is it and how things are. You as a first header or a practitioner, but also you really need to grasp a mandible. You grasp the mandible at its angle. So by grabbing the mandible at its angle and lift the mandible forward, you leave it forward such that you'll be able to really see. Oh friends, I wish you could do this practically, but I believe you're getting it right as a health first header, but also a medical practitioner. But then, having lifted the jaws and opened the airway with the mandible head's movement, you'll be able to tell and see what is all right. But the safest method of opening the airway is if there is possibility of cervical spine injury, that is going to be what you can do. As there's that, as I told you, the safest method for opening the airway is if there is possibility of cervical spine injury, then do it. That is another way also. Now let's continue. Now, upon doing those things, position the patient, of course, opening the mandible, and of course doing all those possible intervention, do the following. Number one, if there is secretion or vomit present, sanction when available or wipe it clean. You shouldn't leave it there because it would compromise with the airway pattern and would make the patient not really be in compatible position or be breathing with their ease. So you have to act as a first aider, but also as a nurse or a doctor or wherever discipline you are. So another thing you can as well do, go ahead, do not waste time. Place an oropharyngeal or nasopharyngeal airway to maintain the airway. For medical practitioners, they know what oropharyngeal is and nasopharyngeal is. But for a first aider, these are I just want you to know, these are it is the device that we always use them in airway to open airways for patients to really get them well. So maybe you can have you can visit one of the facility which is nearby you. Then you interact with your health practitioners. If you're a first aiders who is not a Lancet professional, you get to know. You reach out to them and ask them about nasopharyngeal and oropharyngeal devices. They will be able to show you practically, but also tell them the use for those who don't know it. Then the next thing, having placed an oropharyngeal and nasopharyngeal airway to maintain the airway, you would be able to see this patient if he's able to really adopt or regain that pattern back. But also, if there is a foreign body which is suspected, if the object is visible, remove it, but be careful not to push the object any deeper, because by doing that, meaning you really added more complication and you've done more harm. So you have to be careful and let the object not go deeper. If the patient is able to cough or make noise, keep the patient calm and encourage the patient just to cough. Keep that patient calm. If he's able to cough or make noise, keep the patient calm and encourage the patient to cough. By the virtue of coughing, that force would expel the foreign objects out of the airway. So that's what you're going to do as your management. Let's continue with another management. If the patient is choking or is unable to cough, then or not making noise, use age-appropriate chest thrust, abdominal thrust, or in other words, we call it back blows. We call it back blows, but you have to do it with soft skills. Yeah, don't just go in that way. So you have to use age-appropriate chest thrust and abdominal thrust or back blows. Why do they say age-appropriate? Because for children, you know which amount of energy you have really to put for the back blow or chest thrust. You'd have to know that. But if it's an adult, also you know the magnitude of force that you're going to apply. Then, After that, if the patient becomes unconscious while choking or follow a relevant, what you have to do, you have to follow relevant CPR protocol. For a first aider who do not know what CPR is, it is chest pulmonary resuscitations. So what you do chest pulmonary resuscitation as soon as possible. You follow the protocol. But for also, if you're doing that, consider placing the patient in a recovery position. If the rest of the ABC is normal and no trauma is suspect, that's when you're going to do that. But also, if the patient has swelling or hives or stridor, consider severe allergic reaction, which is anaphylaxis, and give intramuscular adrenaline for those for such a patient. So by that, meaning you've done it, your management, you've done it, and then after doing it, you have to do the following. Do now the breathing assessment again. Look, you have to look and also listen and feel to see if the patient is breathing. Yeah, you are doing your evaluation. But also you are going to go ahead and assess if the breathing is very fast, or very slow, or very shallow. That is now when you come now to critical thinking and intervention and other things as colleagues. Also, you look for a sign of increased work of breathing, such as accessory muscles used, cess indrawing, retraction, and nasal flaring, or abnormal chest wall movement. And then the next thing you should also do is that listen for abnormal breaths, such as wheezing or crackles. But also go ahead with severe wheezing. They may be limited or no breath sound. So on examination, because narrowing of the airway may be so severe that breathing cannot be heard. So listen to see if breath sounds are equal on both sides. By use of maybe stethoscope, probably by use of stethoscope, that is what you should now do. But there are other techniques that you can also, as well apply with your skills that you really, because every practitioner has ways of doing this procedure. But also you have to go ahead and listen to see if breath sounds are equal on both sides, and check for the absence of breath sounds and dull sounds with percussions on one side. When you percuss on one side, also you do a large pleural effusion or hemothorax. By that, you'll be able to tell the status of the patient. But also, if there are no breath sound on the other, if there's no breath sound on the other side, then you have to. There's hypotension. Check for distended neck veins or a shifted trachea. This is now a complicated part of it. We need now a trained personnel. Then, of course, you'd probably be able to rule out tensions of pneumothorax or some possible intervention that could really be for this patient. And then the next thing also, you have to check for oxygen saturation with pulse oximeter when it is available. For those who would use pressure monitor, it's okay. You also have to do that. You really check oxygen saturation. And then another thing here, if the patient is unconscious with abnormal breathing, start back valve mass ventilation, and you have to follow relevant CPR, cardiopulmonary resuscitation protocols. For ensure this patient now, you give supportive oxygen to this patient. If not breathing adequately or too slow for head, too shallow, begin back valve mass ventilation with oxygen. If the oxygens are not immediately available, do not delay, please. Do not delay. Do ventilation. Start ventilation when oxygen is being prepared. If breathing fast or apoxis, give oxygen. You don't need to wait. Then you wheezing. If that patient is wheezing, consider giving nebulizer or salbutamol. Repeat salbutamol as needed to stabilize the patient. If the constant for severe allergic reaction or anaphylaxis persists, give intramuscular adrenaline. That's what you have to do for such patients. But if breathing suffers or apauxis, give oxygen, as I told you. If wheezing, consider giving nebulizing salbutamol or repeated salbutamol as needed, and treat underlying cause as well. But also, if concern for severe allergic reaction, as I told you, give intramuscular adrenaline. If the concern of heart failure, provide oxygen required and get help, treat as appropriate. Breathing management, that is how we do it. If the concern of the tensions of pneumothorax, perform needle decompressions immediately. That is for a trained personnel, but not now for a first aider. That's now a technical part of it, because I don't really expect you, a first aider, to really perform pneumothorax or perform needle decompressions. And give IV fluids and oxygen. You want things. The next thing that you are going to do, you also go ahead and do chest tube. Should be inserted. Plan for rapid handover if at all you are making referral, and transfer, especially if you cannot insert this the chest tube. If the concern comes for the large pleural effusion or hemothorax, gives oxygen. And plan for rapid handover and transfer if you're really doing so. And then, if sucking chest would open pneumothorax, apply 3-sided occlusive dressing while arranging for the chest tube. Then the next thing, many of the life-threatening breathing conditions require chest tube insertion. If unable to perform this, refer after initial resuscitation. You are saving life if you're doing that. Friends, this is a beauty. God gave us these hands to save lives. That then we have to be obedient and faithful to God's gifts that gave us all this. We didn't have it because we were having it, but it's only that it's because God loved you really to serve His humanity. That's why we are here for that. So that is what you're going to do. And then for this presentation, friends, if you know it has been of help to you, please drop the comment. If you really like this video that to be continued, please go ahead and also click subscriptions. That means you are really giving us more time and you want us to bringing more educative things. Then for you can also go ahead and also like the video and do some intervention. So friends, that's what I would want you to know as you practice this. Remember, every single act that we do save lives. God bless. Thank you.